Welcome back to the Irish Haematology Oncology podcast and to our final daily dispatch from the ISOPP CAPhO 2025 symposium here in Victoria, Canada. I'm Owen Tab, and this episode wraps up our coverage by looking at the key sessions from day 4, Sunday, the 6th of April. If you haven't caught them yet, the recaps from days 1, 2 and 3 are available, covering a huge range of topics from the conference. Final day continued the high standard, kicking off with important clinical updates in lung and urothelial cancers. We then had a rapid fire abstract session. I'll cover the ones I caught, followed by discussions on bringing cancer care closer to home, expanding the scope of practice for pharmacists and technicians, and innovative models of care in breast cancer. So let's dive into the highlights of that final day. So the first session provided clinical updates in 2 key areas, presented by Glenn Myers and Dawn Workenton. Glenn Myers focused on locally advanced metastatic urothelial cancer. He reviewed the rapidly evolving first-line treatment landscape, moving from the historical platinum-based chemotherapy towards immunotherapy combinations and antibody drug conjugates. Key milestones include how cisplatin and gemcitabine in immunotherapy maintenance with avelumab, and now 2 major practice-changing regimens, nivolumab plus gemcis from the Checkmate 901, the ADC-IO combination of enfortumab vedotin plus pembrolizumab, which demonstrated a remarkable near doubling of median overall survival and progression-free survival versus chemotherapy in the EV30. Glenn details the distinct adverse event profiles. Nivo plus cisgem primarily involves hematologic toxicities, while EV and pembro requires vigilance from peripheral neuropathy, skin reactions, including severe ones like Stevens-Johnson syndrome, hyperglycemia, ocular disorders, and immune-related adverse events. He stressed proactive patient education, monitoring strategies, including awareness of typical onset times for specific toxicities, and guideline-based management involving holding doses or reducing doses and supportive care. Then Dawn Workenton then updated us on ALK-positive non-small cell lung cancer. Our ALK rearrangements occur in about 2 to 5% of non-small cell lung cancer cases, often in younger or light smokers. The treatment landscape has evolved rapidly with increasingly potent ALK tyrosine kinase inhibitors, offering better CNS penetration and broader coverage of resistant mutations. She compared the first-line options, first generation crizotinib, second generation alectinib, and brigatinib, and third-line lorlatinib. Data from key trials, Alex, Alta, L, and the Crown studies show significant progression-free survival improvements with the new agents over crizotinib, with lorlatinib demonstrating particularly impressive long-term progression-free survival. The median for progression-free survival was not reached at the 5 years mark in the Crown trial, and impressive intracranial control as well. However, toxicity profiles differ amongst these. While all of them can cause GI issues and fatigue, lorlatinib is notably associated with hyperlipidemia, which was both hypercholesteremia and hypertriglyceridemia, edema, gain, and distinct CNS effects. So cognitive issues like brain fog, mood changes, speech difficulties. Dawn emphasized a pragmatic approach to managing these adverse events. So prepare, educate the patient and caregiver, monitor, manage, so use mitigation strategies in place. So introduce dose reductions or dose interruptions where necessary, and reassess then. So it was the PMMR model that was kind of used there of prepare, monitor, manage, and reassess. Importantly, dose reductions for lorlatinib CNS effects or alectinib toxicities do not appear to compromise efficacy based on available data. So there was a question from the audience as well. Well, if that's the case, why would you not dose reduce up front and maybe escalate based on tolerability at that dose, rather than going in hard at a high level and then dose reducing after toxicity. Clinical practice seems to suggest that some oncologists are using that approach. Managing weight gain involves lifestyle counseling, but caution is needed if considering weight loss medications like GLP agonists, citing a study showing semaglutide significantly reduced alectinib exposure. Proactive counseling and management are key to maintaining patients on these effective therapies. Next was a session presenting selected abstracts. I managed to catch 2 interesting presentations before having to take a call, unfortunately missing the last 2. So first, Lisa Chu from Singapore presented on AI-driven optimization of cytotoxic drug compounding. They highlighted the significant issue of chemotherapy wastage from unused portion in vials, leading to high costs and environmental impact, especially as vial sharing is often prohibited under GMP standards. Their project developed AI algorithms, so using dynamic programming and machine learning integrated into a calculator to optimize vial selection based on prescribed doses for robotic compounding. A proof of concept analysis at the National Cancer Center in Singapore identified over $2 million in wastage over 9 months, primarily from expensive biologics like pembrolizumab and high-volume drugs like gemcitabine. The AI prototype successfully optimized order lists to achieve zero wastage during production, and the project was projected to save over $5 million Singaporean dollars annually and significantly reduce hazardous drug waste and CO2 emissions. Ongoing work involves integrating this with large language models and hospital systems. It's a fascinating application of AI for efficiency, cost saving, and sustainability. Secondly, Adrian DeBoer from Canada. DeBoer from Alberta, Canada, discussed evaluating the impact of a pharmacist-led venetoclax ramp-up clinic for CLL patients. Given the intensive monitoring required during the 5-week venetoclax dose ramp-up to mitigate TLS risk, they implemented a pharmacist-led clinic where pharmacists independently assess patients, order labs, manage TLS prophylaxis treatment, and handle other adverse events. Did I say what TLS is in here? Tumor lysis syndrome. They titrate the venetoclax dose. A retrospective review of 88 patients showed that the model was safe and effective. 94% reached the target dose with very low rates of laboratory tumor lysis syndrome and 0 clinical tumor lysis syndrome of those patients who went through this clinic. Pharmacists made frequent interventions, particularly around tumor lysis syndrome prevention and education. This study strongly validates the role of pharmacists working at full scope in managing complex initiation protocols like venetoclax ramp up safely and effectively. As I mentioned, I unfortunately had to step out and I missed the final 2 abstract presentations. So Joe Williams, then chair of BOPA in the UK, gave a compelling talk on cancer care closer to home, addressing the significant capacity crisis facing cancer services, particularly SAC delivery in the UK and likely mirrored elsewhere. He highlighted rising demand, so a 6 to 8% annual increase in SAC activity, workforce shortages across the MDT, oncologists, nurses, pharmacists, and issues with aseptic compounding capacity, all contributing to treatment delays that impact patient outcomes. He presented care closer to home as a key strategy to alleviate pressure and improve patient experience. Models discussed included outsourced home care. So this is where commercial providers are delivering oral medications or administering injectable SAC at the patient's home. This offers benefits like VAT savings on high-cost drugs in the UK. It's an initiative for them whereby the drugs, when they are delivered to a patient, the hospital does not have to pay VAT on the drugs, reduced hospital pharmacy workload, and patient convenience. And then there's internal home care services, so trust-led initiatives like Christie at Home, where dedicated teams of nurses and pharmacists provide SAC administration in the patient's home. Selection criteria focus on lower risk treatments. So, for example, from cycle 3 onwards with low hypersensitivity risk, non-vesicants, shorter infusions or subcut infusions, patient suitability. Closed system transfer devices are used for safety. This model has shown significant growth and a high patient satisfaction, reducing travel burden and costs, improving quality of life, and allowing patients to return to work and leisure activities. Some examples were that patients who were working from home didn't need to actually take a day off in order to attend a clinic, because the vial was sent to the home, and then the nurse followed and was given it on the day. So they were just working for the day, and the nurse came and administered their and decentralized clinics, so utilizing mobile units or community-based facilities to deliver SAT, bringing care into the local areas. So barriers do exist to developing these services, including complex prescription pathways for home care, logistical challenges in reporting this back to the health service, and ensuring safety for lone workers. However, the overall benefits for patients, which is it's more convenient for them, they're able to access the service at a quicker time, improve quality of life for them, and reduce costs or time toxicity as well for them. There's benefits to the health system, so you're releasing that capacity and potential savings as well, depending on how you're costing chair time and things like that. And benefits to society as well, so reduced CO2 emissions and people being able to return to work are substantial. So the key message was that while no single solution exists, decentralizing care through various closer to home models is a vital tool to manage capacity constraints and improve patient-centered care. So following on from this, a lively panel discussion featuring Molly Bishop from the UK, who's a pharmacy technician, Michelle Koberinsky, sorry if I pronounced that wrong, who is a pharmacy technician in Canada and the new head of CAPhO, and president of CAPhO is probably the correct term, Laura Minard, who is a pharmacist in Canada, and Tiffany Chan, who is a pharmacist in the UK. So they all explored practicing to full scope in oncology pharmacy to improve patient care, focusing on pharmacist prescribing and expanding technician roles. The panel compared the roles and qualifications of pharmacists and technicians in the UK and Canada, noting differences in regulation, but a shared direction towards maximizing contributions. Pharmacy technicians are increasingly undertaking advanced roles like screening SACT orders, managing inventory, providing education to patients on their first cycle of treatment, and performing final product checks, checking techs, provided they have the appropriate training, competency assessments, and clear protocols in place. Regarding pharmacist prescribing, the UK's established independent prescribing model was contrasted with the varying provincial models in Canada, which often involve collaborative practice agreements or specific prescribing authorities. The panel expressed strong enthusiasm for pharmacist prescribing, viewing it as essential for optimizing patient safety, reducing delays, and fully utilizing pharmacist expertise. Although limitations in scope or institutional policies can sometimes be restrictive, and sometimes that's a resource issue as well. One of the points raised from the audience was that if you have pharmacists prescribing something, who's checking that? So whereas there has to be a pharmacist to fill that gap of doing a check on that prescription, you can't check yourself. The benefits of expanding scope for both roles were clear: improved efficiency, enhanced patient access and safety, reduced workload for other healthcare professionals. That was probably the main driver for a lot of these things, was that you are expanding your role as pharmacists to alleviate pressure on our nursing, our medical colleagues, and as such, with that role being expanded by pharmacists, the technicians are filling the gap to expand their role in order to fill the gap that has been created by the pharmacist. But who's filling the technician's gap was a question that was posed as well by the audience. And it also showed increased job satisfaction as well. So, however, the panel was also addressed concerns, emphasizing the need for robust training and competency frameworks, clear governance structures to manage liability, adequate resources and funding, and proactive engagement with other professions to ensure smooth integration and address any resistance to change. Implementing these expanded roles required a multi-pronged approach, strong advocacy from your professional bodies and leaders, demonstrating value through pilot projects and data collection, developing national training standards and registering of technicians as well as essential, and credentialing where needed, supportive regulatory changes, and fostering a truly collaborative, multidisciplinary culture within healthcare institutions. So the final clinical session showcased innovative models of care in breast cancer from Canada. This was moderated by Scott Edwards, featuring Elaine Goh, Mary Youssef, and Anik Dufour. These models aim to address increasing patient volumes and treatment complexity, particularly with the rise of oral anti-cancer agents like CDK4/6 inhibitors. Elaine Goh described the medication assessment by pharmacists program at BC Cancer Surrey. Stable patients on selected oral therapies, so initially CDK4/6 inhibitors, and that has been, I think, slightly expanded, have scheduled follow-up appointments with a clinical pharmacist instead of the oncologist for medication assessment, toxicity monitoring, adherence checks, and prescription renewals. This successful shared care model, now recognized as a leading practice by Accreditation Canada affiliates, significantly frees up the oncologist clinic time for new or complex patients while providing focused medication management support and convenience for patients by having that pharmacist expert in the room for the follow-up visits. Mary Youssef then, she detailed the implementation of a pharmacist-led CDK4/6 inhibitor clinic at Trillium Health Partners in Ontario using the PRISM implementation framework and strong multidisciplinary collaboration. So oncology, pharmacy, nursing, informatics, leadership teams, patient representatives, they were all involved in the development of this clinic, and they established a clinic where pharmacists manage patients on these agents, focusing on side effect monitoring, education, and ensuring adherence. Key success factors included defining clear roles, developing standardized protocols, establishing communication pathways, and securing administrative support as well. So challenges involve resource constraints and ensuring acceptance of the pharmacist role, but it was still a great success. Anik Dufour then, she presented Quebec's province-wide tele-home care monitoring service for patients on oral anti-cancer therapies. So this utilizes a virtual platform where patients report symptoms guided by algorithms based on PROTECT and pro-CTCAE. Oncology pharmacists follow up, especially with vulnerable patients identified via community pharmacy collaboration, providing proactive adverse event management and support remotely. This model enhances access and provides timely intervention for patients across a wide geographic area. The overall discussion highlighted the growing need for such innovative, pharmacist-involved models to manage increasing workloads, optimize the roles of different healthcare professionals, improve patient access and experience, and ensure safe and effective use of complex therapies like CDK4/6 inhibitors, particularly as their use expands into adjuvant settings. So, summarizing the key learning points from our final day: lung and urothelial cancers, so practice is rapidly changing with new combinations in enfortumab vedotin plus pembro, nivo plus cisgem in urothelial cancer, and the potent TKIs, so lorlatinib in ALK-positive non-small cell lung cancer, improving outcomes but requiring proactive management of distinct toxicity profiles. So watch out for your neuropathy, your skin reactions, your hyperglycemia, your CNS effects, your hyperlipidemia, weight gain. Looking then at the abstract highlights, so AI shows promise for reducing chemo compounding waste. Pharmacist-led clinics are safe and effective for managing complex initiations like venetoclax ramp-up. Looking at care closer to home then, so it was an essentially strategy to manage the capacity crisis in the UK. It has led to improved patient experience and access. It requires innovative models, so home care, decentralized clinics, and it requires a massive overcoming of logistical and safety barriers. but it has shown to be done. So there was the expansion of roles by pharmacists and technicians then, so maximizing pharmacists, so via prescribing and their clinical services, and the expansion of technician roles from screening, checking, patient support roles is key to efficient, safe, patient-centered care. It needs advocacy from your groups, it needs training, and it needs the resources to implement. And then looking at those different breast cancer models, so pharmacist-led clinics and shared care models, are effective in managing oral therapies, improving access, and optimizing MDT roles. Very important there to maybe look at, if you are going to start, do you just implement for a small number of oral anti-cancer treatments? Do you just have your own little clinic for CDK4/6 inhibitors or something like that to get the ball rolling? So that brings us to the end of not just day 4, but our entire series of daily dispatches from the ISOPP CAPhO 2025 symposium. It has been an incredible, insightful and stimulating few days here in Victoria, covering a vast range of topics critical to advancing oncology pharmacy practice globally, and here in Ireland. I'm full of enthusiasm going home now and trying to get my teeth sunk into things. Looking at cutting edge therapies, personalized medicines with pharmacogenetics and therapeutic drug monitoring. Couple of safety talks were great as well. The different innovative models of care that people are doing globally, addressing equity, diversity, and inclusion in your practice, looking at sustainability as well, and then looking forward towards the future with AI and our expanded scopes of practice. There's so much that I've had to take back and reflect on, and hopefully I've told you, given you enough details, but please do contact me if you want any more details about any of the talks in general. Hopefully I'll be able to remember and pass on some insights to you. And I've made a couple of contacts here as well, so I might be able to put you in contact with them if you're interested in developing any of these services. I hope you found these daily recaps useful. A huge thank you for tuning in throughout the week. As always, your feedback, questions, and suggestions are welcome. Reach out via Spotify comments, Instagram at Irish Hemonc Pod, or email the Irish Hemonc Podcast at gmail.com. Big thank you to all of the committee at ISOPP and CAPhO for organising a great event and being so welcoming for the whole thing and being very inclusive with me and all of the delegates here. So just to finish on our disclaimer, this podcast is for educational purposes only and reflects summaries of presentations attended at ISOPP CAPhO 2025. The content of this has not been reviewed or endorsed by ISOPP or CAPhO. The field of cancer care is constantly advancing. Always consult with your own clinical team and refer to local institutional guidelines and trusted national resources for the most up-to-date recommendations and personalised guidance. Thank you once again for listening to all of these episodes of the Irish Hematology Oncology podcast. Until the next time, thanks a million, and I'll see you soon.